Good evening, ladies and gentlemen. Welcome to the seminar by Professor Terry Lum. It's my great pleasure to be the moderator this morning. I am Professor okay, from the Department of Social Work and Social Administration. I'm afraid I don't need to introduce Professor Lum because he is so famous in gerontology and also, in really designing effective mental health services for elderly in the community. Perhaps before, but anyway, that is my duty to introduce Professor Lum. But before that, maybe I tell you a short, interesting story about the step care model, and also one of the most important pioneer of the step care model, Professor David Goldberg. Okay, so Professor David Goldberg, proposed the idea of community psychiatry. So the core idea is very simple. Okay, he believed that most people with mental disorders could be managed really well by family physician. Okay, and in the UK they have a really comprehensive family doctor system. Okay, so that is the whole idea. So along this line, Professor David Goldberg developed pragmatic comprehensive training for family physicians to take up the job, and also developed the famous GHQ. Okay, by now we are still using the GHQ as a screening tool. Okay, and then he also one of the founder of the step care model. Okay, so the idea is simple, but it also got severe limitation because the step care model is still limited in the medical, domain. But we understand the need for mental health service far exceed the capacity of the medical domain. Okay, so today, Professor Lum will tell us a solution. Okay, so that is a community collaborative approach. So I leave that important task to Professor Lum. Okay, so sorry, I tell the interesting part first. Okay. So I was so fortunate to have the opportunity to study under Professor David Goldberg when he was the head of department of the Department of Psychiatry at the Manchester University. So during that time, I was studying psychiatric social work in the 1990s. So in private, okay, in one conversation with Professor David Goldberg, okay, we asked Professor Goldberg, okay, so mental health service, bound to be offered by a multidisciplinary team, so including like psychiatrists, psychiatric nurses, psychiatric social workers, psychologists, occupational therapists, etc. So we asked Professor Goldberg a very tough question. So if because of resource limitation, if you could only pick one discipline to work with you, which discipline will you pick? Make a guess what would be his response? Without a second thought, okay, he chose social workers. Why? We asked why. Because social workers, could be good supplement and complement to what he can do. Okay, I think that also highlights, Professor Lum's brilliant idea about a collaborative approach. Okay, so something the medical system can do, and the community, so services may not be able to do, but the community domain could do something the medical system cannot. Okay, so and nowadays I tell you one important note. When we come across Professor David Goldberg, we can't call him Professor Goldberg anymore. We need to address him as Sir David. Yeah, you know what I mean. Okay, so I pass over to, I need to introduce Professor Lum. Professor Lum is Henry G. Lum, professor in our department. Okay, and he is expert, in gerontology and also mental health services for the elderly. And he has got multiple grants from the Hong Kong Jockey Club to realize his dream and the ideal system, really to provide comprehensive mental health services to the community, to the elderly in the community. As I pass over the time to Professor Lum.
So thank you, Silman. But before I start the formal presentation, allow me to speak a few sentences in Cantonese. Because I know that 有啲peer supporter 我哋嘅今日喺度嘅即係我估多謝衷心多謝啲我哋啲 collaborator working together 啲 peer supporter 今日嚟到呢度啦，因為知道出席一個學術嘅喺大學一個研討會唔係一個咁即係咁容易嘅事或者咁 easy 嘅事，咁我估係今日嘅 presentation 咧，其實唔係關於我，亦都唔係關於我哋 Hong Kong U， 係關於我哋成個 Joyce 嘅 team 咧，就包括埋每一個 peer supporter 喺呢處或者唔喺呢處，亦都包括我哋嗰200幾位 social worker， 亦都包括我哋有成6600個ambassador， 佢係喺我哋呢個 program 入邊高呼咗一個訓練，同埋亦都喺我哋 promote community mental health 上邊咧，即係呢個社區入邊精神健康入邊出咗一分力。咁所以喺處 before 個我哋做個正式嘅 presentation， 衷心多謝每一位即係喺入邊嘅會員啦。咁 let me go back to the presentation. So actually this is about a story that has been kind of making and still ongoing for since 2016. And then, so it is close to 8 years, and then still we have about 2 more years to go. So the title here is Community Collaborative Approach, right? So community and collaborative, these are the 2 key words. But before that, let me give you a little bit about the background, right? So about 1/3 of the people in Hong Kong are 60 and over. So it is not a trivial number. It is not a small number. So, and then this is the latest, from the government census. That means 1 in every 3 Hong Kong people are older adult if you use 60 as a kind of cutoff. And then that number, that proportion will increase to about 40% in the next 2 decades. So we are talking about 40% of all Hong Kong people. And from, a different local community survey, we know that about 10% of older people has a clinically depressive symptom. That means 1 in every 10 people, older people, will have clinically significant or clinical depressive symptom. So with the population aging, this will become a really big social problem, right? And then we also have big social costs or medical costs related to treating mental illnesses. So however, if you look at the number, this is the suicide rate in Hong Kong by different age group. So we heard a lot about the increase in suicide, rates for, let me see, for young people, right? So this is a number of suicide per 100,000 people. So if you look at this, is from 2014 and ongoing. So it is increasing. This is, if you look at the age group, this is below 15 years old. So it is increasing, right? And the second number is 15 to 24, increasing. The third line is 25 to 39, kind of flat, but still increasing. And then the next number is 40 to 59, flat, but still a little bit increasing. This is a number for elderly. So elderly, number 1, we still have the highest suicidal rate in Hong Kong compared with other age group. But over the years, what you see is interesting, right? All the age group are kind of increasing, except the elderly. So the elderly are in fact are decreasing. So even despite the COVID-19, despite we talked about the caregiver stress, the healthcare problem, the suicidal rate of older people, in fact, if you compare with 2014, 2015, 2016, 17, it is significantly decreased. So the question is, it seems that we are doing something right in the community, right? When all other age groups, the suicidal rate are increasing, except elderly. So this is a story about, we try to guess what is happening here. So this is the implementation timeline of the Joy Age project. So we started from 2016 as a pilot in 4 districts in Hong Kong. And then 2019, we finished the pilot with really good results. And then the Jockey Club agreed to expand the program. So from 2020 to 2022, end of 2021, it expanded from 4 districts to 12 districts. That means we add 8 districts into the project. And from 2022 to 2023, end of 2023, we add another 6 districts into the project. So by 2022, all 18 districts in Hong Kong has a joint age implemented. And then if you look at the number here, it seems that when we start the joint age and when we expand the joint age slowly, but gradually, the number of the suicidal rate for older people are decreasing, right? So this is not causal relationship, but at least it is a nice correlation that we want to show it here. So the joint age project are initiated by the Hong Kong Jockey Club with Hong Kong U as the academic partner. But as I said, we also have a large number of community partners. So we have 18 NGOs who get the resources from the Hong Kong Jockey Club to implement the project. So each NGO, we have also 51 centers right now as of this month who are implementing the joint age community intervention. So each center, we add 2 full-time staff into the project. So one is a mid-career, hopefully. We have resources for mid-career social worker. Another one is a program worker. So with this scale, right? So it is not something that a small academic project working on a few people, but it is a large scale implementation. So in the last 8 years, we trained more than 6,600 mental wellness ambassadors. So they received the mental health first aid, and then they did a practicum in the community. And then they also agreed to volunteer in mental health related projects, as well as to kind of help take care or keep an eye on people around them in the community member. And then we train more than 900 older people as peer supporters. So they are the people who receive almost 100 hours of training. They work alongside with the social worker. So they provide peer support for older people who have depression. So on one hand, these older people are receiving psychotherapy or a psychosocial intervention from the social worker, but the peer supporter work with them in the process. So we also train 208 social workers to deliver evidence-based intervention directly, in elderly or mental health centers in the community. So before they can start their intervention, so these are the people who already have a degree in social work. But before they can start the intervention, we need to make sure they go through more than 200 hours of training, including both theory, clinical, as well as shadowing from our clinical supervisor. And then since 2016, we have successfully reached more than 100,000 older people in our program. And then we also provide direct clinical intervention for more than 10,000 older people who have subclinical depressive symptoms. And then our results show that 92% of them show a very significant improvement in their depressive outcome, after the intervention. And we also did a cost and benefit analysis. Every single dollar the Jockey Club invests in this program will save the healthcare system about $2.14. So this is a quick summary of the impact. And then, as I said, since 2022, the pilot has expanded from the program has expanded from 4 pilot districts to cover all 18 districts in Hong Kong. So we have 51 services units, including 48, district elderly center or district mental health center, plus 3 district health center who are implementing our protocol. So that means we have at least 1 center in every single district who are providing community-based mental health services for older people. Before that, the services are provided mainly in the hospital system. Older people need to go to a hospital for treatment. Now they can get evidence-based psychotherapy within their own district by social workers who are trained to deliver the evidence-based intervention. So the money, the initial funding from the Jockey Club was $87 million, including some of the money go to HKU. Large part of the money go to the community, to NGO, to support their implementation. And then in 2020, the Jockey Club further expanded investment to $279 million to expand it from 4 districts to all 18 districts. And then in 2024, we get another round of funding from the Jockey Club to not only continue the program in the community, mental health and elderly district, but also expand it to district health center. So trying to build a permanent mental health care system for Hong Kong. So our work is not top down. That means people in academic develop the model and then implement it in the community. Instead, from the very beginning, we use a bottom-up approach. So when we got the money, the grant approval from the Jockey Club, the first thing we did is we also get the approval from the Jockey Club to allow us to have about half a year non-productive period. That means we are not going to see a patient, a client, but we work with the social worker, with the NGO to co-develop the clinical model. And then, so we have our contribution. We know what is evidence-based intervention. So we have our expertise, but the community also has their expertise. So we work together to co-create the intervention model, the step care model. So we have a lot of focus group with providers, with NGO social workers, with community stakeholders. And then we also have individual interviews with social workers as well as with community stakeholders. And after that, we put together what we call a theory of change workshop to bring the people together to brainstorm what we can do in the community. And from there, we start, to think about the professional training the social worker need. And then we have our clinical team. We form our clinical team to develop the curriculum for professional training. We also start using a community approach to engage the public to promote mental health literacy in the community. And then throughout the 6-7 years we implement, we did a lot of community intervention. We did a lot of community talk. We have press conference. Furthermore, we also have bottom-up community-based participatory work organized by our peer supporter as well as our ambassador to promote mental health literacy within their community. We did a lot of sharing of knowledge with stakeholders, local, government, as well as international. And then we also share our wisdom, what we learned with international organizations, as well as governments in other countries. So, but if you kind of make a quick conclusion, we only did two things. One is we make evidence-based psychosocial intervention readily available in the community. So older people don't need to travel a long distance to get help. There are always help available in the community. Number two is we initiate a very large-scale community-based participatory approach to kind of build a safety net in the community so that we have more than 6,600 older people who receive the mental health first aid in the community. You divide it by 18 districts, right? That means in each district, on average, we have more than 300 older people who know mental health first aid in the community, right? So that means if you are living in the community, very likely you will have a neighbor, you will have one of your friends who know mental health first aid. So when they are walking around in the community, they are aware one of their neighbor used to be very active, come to the elderly center, come out to chat with people, or go to the park, but suddenly disappeared, lock himself or herself in the room, right? Then he or she, the ambassador, will start thinking about this may be something wrong or some mental health issue going on, right? And then he or she can start the process. We don't expect them to provide any intervention, right? But we teach them the community resources that is available in the community so that they can escort their neighbor to an elderly center who has a social worker trained to provide the services. So this is the community-based approach we build within this program. So let me talk a little bit about the collaborative step care approach. So basically, number one is collaborative. That means traditionally, our mental health system are run by psychiatry and clinical psychologists. But in Hong Kong, we only have a little bit more than 400 psychiatry to take care of more than 7 million people. We have a little bit more than 600 clinical psychologists to take care of, 7 million people. So no matter what we are going to do, we are not going to significantly expand the number, increase the number of psychiatry or clinical psychologists in the next decade. So without increase in manpower, there is no way we can enhance our mental health system. So our approach is, number one, train social worker to provide the services. Number two, train older people to become peer supporter. Number three, train other older people to become ambassador. So the peer supporter now come from ambassador. So they receive the first round of training, they volunteer. If they find out this is something they really want to commit, and the social worker also found out they have a skill set to become a good peer supporter, then they will be invited to go through the peer supporter training and become a peer supporter. So it is a kind of step-by-step process to moving older people from a recipient of services to a participant and then to a co-producer in the process. So it is a collaboration. And then the social worker, each district, we have at least one social worker, but in many districts, it has at least two social workers who are trained to provide the evidence-based intervention. And then we also have two program workers who work with the community. So we kind of look into the symptom, depending on the severity, right? If it is mild, then the services will be provided in the district elderly center. If it is moderate, depending on whether they have a suicidal risk or not. If not, then still the services are provided in the community elderly center. But if it is moderate, high, then it will be provided in community mental wellness center. And if it has suicidal risk, then it will elevate to the medical setting. So that means if we can catch people early on, when they have mild symptom to moderate symptom, but without suicidal risk, we make the psychotherapy or psychosocial intervention available right at that time. And then older person can go through those interventions before their symptoms become very serious, right? So if we can stop the process right there, reverse the process, then we can help people instead of them waiting in the waiting list for the healthcare services from the hospital authority. And then their situation further deteriorate to become suicidal, right? So they can receive psychosocial intervention within their own community. They are supported by peer supporter. They are also further supported by the ambassador. Then likely we can reverse the process before it becomes too serious. So this is our step care model. So we are not only talking about social worker, we are also talking about a large number of older people who are working with us in the community, so that it is not the 200-something social worker who deliver. We are talking about close to 1,000 peer supporter, more than 6,000 ambassador in the community. So impact on and with older people, right? So so this is the outcome, right? The joint step care model is significantly more effective in reducing depression and anxiety symptoms compared with the services as usual. So this is from our research in the pilot project. So in the pilot phase, we have both intervention group and the control group. So we compare services as usual in the control group versus, the intervention group. So impact on peer supporter. So for the peer supporter, we found out the joy age experience and the training improve their sense of meaning and hope and sense of peerness and companionship in their process of supporting others in the mental health recovery process. So, and then impact on the healthcare system. So joy age is cost effective in gaining additional depression-free day and quality adjusted life year compared with, usual care. Every dollar invested in joy age saves the healthcare system about a little bit more than $2. So we look into, the before and after, right? So if you look at the chart here, this is the THQ score. That means the depressive symptom score before intervention. This is the depressive symptom score after intervention. So on average, for the 10,000 people we have provided services, average is 8.64 when they get into the program. By the time when they discharge, it is 3.21. And the score 4 or below, we don't classify as clinically, depressive cut off. So, and then we also look into anxiety as well as loneliness. They also show a significant improvement before and after the intervention. And then if you look at, when they enter the services, we look into, their step down to the services from, so this is whether their score, the severity of their depressive symptom before and after. So before, most of the people are in mild to moderate level depressive symptom. But at the time of discharge, most of them are below 4 in the mild symptom or even lower. So this is the effect. So these are some of our activities we do with the older people. So peer supporter is a core component of the intervention. So they are our partner. And then some of the peer supporters themselves also went through the depression, symptoms. So they are first client, then they become ambassador, then they become peer supporter. So these are 2 examples of our peer supporters who has been working with us for a long while. So this lady, Man Man, actually just got an award from the Hong Kong Council of Social Services for her contribution to peer support services in Hong Kong. So we also, this is a newspaper article last year when we have the graduation of the peer supporter. So remember, we have over 9,000 peer supporter graduate. But since 2020, we have the pandemic. That means peer supporter who graduated started from 2020, they do not have the graduation ceremony. So wait until 2023, right, when the pandemic is over. We bring all of them, more than 500 people together in an event to kind of celebrate their graduation, as well as to thank them for the contribution to promote mental wellness in Hong Kong. So the second component, community-based participatory approach, right? So we kind of know that only providing clinical intervention is not the solution. We need to do a lot of preventive work. And the preventive work cannot be done by professionals because we don't have that many professionals. So the only thing we can do, the most effective intervention, is by the people, for the people, right? By older people, for other older people. So from the very beginning, we start thinking about peer supporter. Because even social worker, no matter how hard they try, at most they may be able to see the older person once a week, right? Or once every other week. So the intensity are not enough. So, but with a peer supporter, they can go to visit the home more often. They can go to have a walk in the park with the older people who are going through the intervention, right? So in the pilot phase, we start training and using, walking with the peer supporter in the process. But started from phase 2, when we do the expansion, we found out maybe it is even better if we can create another category, the ambassador. And ambassador, the training is reduced, so it is not 100 hours of training, it is only about 20 hours of training. But then we have a standard curriculum, the mental health first aid - elderly version. So we work with the Mental Health Association of Hong Kong, and then we train our social worker to become mental health first aid instructor. And then they provide mental health first aid within their center. And then we ask them to train social older person to become mental health first aider and then ambassador. So since 2020 until now, we have more than 6,600 older people who finished the mental health first aid training. So if you, I did the calculation before, right? More than 300 older people finish mental health first aid within each district. So it is a huge manpower who are able to help us to identify older people who are at risk of mental health challenge, right? At the same time, these are the people also, we ask them to visit the district mental health resources so that they are familiar with what resources is available in the district. So when they know their neighbor are struggling with mental health challenge, they can bring their neighbor, they can escort their neighbor to a mental wellness center or to the district elderly center to seek formal help. So they don't need to provide the intervention, but they need to be aware what is available in the district and then share the information with their neighbor. So also started about 2022, we started a community-based participative research, we call it CBPR, in 7 districts. So since we have so many older people in the district, who trained in mental health first aid. Then we ask them if they are willing to form a small group in the district to be in charge, self-governed, self-running, mental health literacy promotion in the district. Then we will form a partner between the NGO, Hong Kong U, and that group working together to promote mental wellness in the district. So our idea was, if you hire a social worker, usually you hire someone moving from one district, work in a new district, right? So that person, when they first come, they know nothing about the district. So they don't have connection. They don't know the resources, right? So if you ask that person, the social worker, to develop program that help older people in the district to be more aware of mental health challenge, to understand the mental health resources, it is very challenging, right? Because that person don't have the knowledge. But the older people, they may already live in that district for 30 years, 40 years, right? They have the connection. They know the district. So if we train them about the resources available within the district, we teach them how to activate those resources, right? Then they will become a really manpower to help improve the mental health situation. So we ask them if we have more than 5 or 6 older people who raise their hand saying that, oh, I want to try. Then we form a partnership between the group of older people, the NGO, and the university to brainstorm what they can do in the community, right? So as of these 2 weeks, we have 6 activities. The October is the mental health month, So we have 6 activities organized by this self-governed group to promote mental wellness. For example, they can have put a station, on the streets, and to interview older people, introduce them the mental health resources available in the district. And if they are interested, they can do a quick screening, depression and anxiety screening. And if they find out that person has some symptom of depression, then they can say, invite them to come to the center for further follow-up. So they also organize some visitation to parks so that to teach older people how to relax. They also visit some visitation to some community-based mental health facility so that they know what is available in the community. We ask the social worker each year to provide at least 12 community talks on mental wellness. So, and then they can do 6 talks within their center, but we also require them to do 6 talks outside their center with other NGO partners or with other settings. This is also help them to spread the news or to help build the community mental health literacy. So by having such a large scale outreach effort, so we were able to really touch a lot of older people, particularly the singleton, 獨居長者 in the community. And so this will become a way that we help build bottom-up strategy to promote mental health literacy in the community. So you may ask, okay, why clinical has a community-based approach, right? But if you look at, for example, this report by the WHO on the decades of healthy aging, one thing that is quite crucial is social isolation and loneliness are really huge problem among older people. And then the best way to overcome social isolation and loneliness is not to provide clinical intervention, right? But to build a connectiveness, to build a social capital among the older people so that they are connected back to other older people as well as to the community. And our CBPR, our ambassador, is exactly doing it. So we did a lot of engagement with the public. For example, we have 2 websites. You may ask why 2 websites. So we have one research website in English for international and researcher. We have one website in Chinese for the community. So we have 2 websites. And then we also have a smartphone app with more than 3,500 downloads. And then we have a Facebook page with more than 6,000 followers. And then we also have a YouTube channel that we put a lot of our mental health related video on the YouTube. And then we do a lot of community event, the public, the community event here. So as of the last few years, we have more than 800 community events that organized by NGO. And then we have 5 family fun days for older people and their old adults. And then we also have public talks to cover topics related to self-care or emergency and bereavement. And then we have local mass media strategy. So we have a public awareness team within my team. So we usually hire reporters from radio or from newspaper or from TV to be our staff to help do the publicity. So in the last few years, we have altogether 56 newspaper and magazine coverage. We have 3 local press conferences. We also have 7 intermedia in international symposia. So our local medium reached about 6.7 million viewership over the last few years. And then we also do publication, but the publication is not academic publication. So we have booklets published in Chinese for the community. So we have a book on prevention of elderly suicide. We have a book on we call 清心生活. It is for older people, behavioral activation during the pandemic, COVID-19. And then we started expansion in 2020, but it was exactly the COVID-19 time, right? So lucky or unlucky, right? So when we expanded from 4 districts slowly to 18, we hit the COVID-19. So one strategy we use is we change our strategy because there is no gathering, right? Even in some center, face-to-face meeting are not allowed. So we develop we call the one call protocol. And then we train our social worker to give a call to people they know in the community who are either alone or who do not have enough support. So between February and August 2020, and then April and June 2022, we actively monitor the mental health status of more than 8,000 older people in the community. So, and then we also, since we all have more than 6,000 ambassadors in the community, we also know a lot of older people in the COVID-19 quarantine, right? They are not allowed to have face-to-face meeting. So how about using Zoom, right? But a lot of older people, they don't know how to use Zoom. So we train 800 ambassadors to become e-buddies. And then they know how to teach older people on Zoom, how to use Zoom. And then they visit those older people, help them to set up the computer or the iPad on Zoom. And then so that they can have psychosocial intervention, therapeutic work over Zoom during the COVID-19. So the e-buddy become a really bridge between the social worker and the older people. And then based on the behavioral activation principle, we also developed this 14-day activity online book, the 清心生活, which we also distribute to older people. While they cannot go outside for activity, they can still do mindfulness activities to help them to really handle the stress related to the COVID-19. This is the community-based participatory approach, right? So at the very beginning, we ask the older ambassador if they're interested, they come to Hong Kong U to start a training. And then after that, we send them out back to their community to identify hotspots or sites in their community that can help people to reduce their stress and promote their mental wellness. And then after small group activities, they bring those resources back to Hong Kong U, and we created what we call a Cantonese 陽山樂圖. And also the 陽山樂圖 is allow the older people in the community to identify within their district places that they can visit, activities they can do to reduce their stress. And then we do a lot of outreaching through the traditional media. For example, we have been on the TV program, 冚能在線. We have been on 鏗鏘集. We have been on radio, 同途有心人. We have been on 精靈一點. And in most of these activities, we also have our social worker as well as our peer supporter as a team, for those interviews. So since 2016, we were invited to share our work in 7 radio interviews and 9 TV programs, and then 56 newspaper and magazine coverage. And then we were also, able to share what we are doing with the government. And because of, the systematic way we are doing during the COVID-19, we were also invited by the UK Parliament, by the Chile government, by the city of Toronto, by Australia government to share our experience of helping older people in the community during the COVID-19. And also, years ago, out of the 500 funded projects by the Hong Kong Jockey Club charities between 2021 and 23, we are one of the 2 projects invited by the Jockey Club to present in an international conference in Thailand. So this is a little bit summary of what we did and the impact. If you want to know more about the detail, go to our research website. So you just search Joy Age at Hong Kong U, then you will find our research website. So the paper we published, the academic output are all in the research website. And then if you are interested in more in the services, go to our Chinese website. So it is for older people, for people in the community. So I want to use the last few minutes to talk about the implementation sciences approach we use in this study. So implementation sciences is kind of new in academics. So it refers to the scientific study of methods to promote a systematic uptake of research findings and other evidence-based patterns into routine patterns. So academic, we are known to produce a lot of evidence, right? Good patterns, but very few of those patterns will become patterns model in the community. So the implementation sciences is a study of what kind of method we can use in academic to kind of enhance the chance of those evidence intervention developed in academic able to be used by the community, by the government, by the funder to become a practice model, right? So the aim of implementation sciences is to translate research to patterns and systematically close the gap between what we know and what we do. So in academic, we are good for what we know, but very few of us are able to really impact what we do. So it ensures science and evidence base has been equitably impact on practice and population health. So it is not just in Ivy Tower, but in the community. And it promotes the adoption and use of evidence-based intervention in real-world clinical and public health settings to improve health and quality of care. So when we develop the Joy Age project, we have this in mind. So we know that it is really not good enough to just have an effective intervention. So we do not want to produce a few high-impact articles and then bookshelf it, right? So we really want to be able to change the mental health status of older people in Hong Kong. We want to lower the high suicidal rate of older people in Hong Kong. So we will not see ourselves as successful if we just produce good science. So we really need to connect what we are doing with the community. And we are lucky in Hong Kong to have the Hong Kong Jockey Club charity to allow such large resources in the community to implement the project. So very often, if you go to other countries, right, the academic may get a grant to develop the model, but they will not get the money to work with the NGO to get the model implemented in the real world, right? So that is the luxury we have in Hong Kong, a very unique opportunity for us. And then for implementation sciences, we use EPIS, right, as 4 steps. So E is the exploration, P is the preparation, I is the implementation, S is the sustainability or sustainment. So if you look into the Joy Age process, exploration phase, 2015, me and then one of the co-PI, Professor Gloria Wong, start to have some idea about, we want to really see whether we can help older people in Hong Kong to reduce the suicidal rate in Hong Kong. So we have an idea. We wrote a concept paper and we start talking with the, a key person in the Hong Kong Jockey Club. And then with their blessing, we start talking with the NGO. And then so we work with the Jockey Club staff to identify 4 districts in Hong Kong. So we look into the Hong Kong map, look into the elderly population in each district. We look into the poverty, percentage of older people living under poverty in this district. So we also look into who are the major NGO partners potentially in those districts. So to select a district, it needs to have high concentration of older people, relatively low socioeconomic status, and strong NGO presence that we can build partnership. So we identify 4 districts to begin with. And then we work with the Jockey Club, and then they start to initiate the project. But at the same time, we also able to build a strong partnership to them so that they do not only focus on, we call the KPI, right? They really allow us time to work with the community to develop the project bottom up. It was a really luxury. So we have half a year to develop the model. We have another half a year to try the model before we frozen the model. And then we have 2 years to do the quasi-experimental evaluation of the project. So that means the Jockey Cup allow us to have 1 year luxury to develop the model, to test the model before we frozen the protocol, and then do the RCT to evaluate the outcome. 2 years later, when we have the outcome, we go back to the Jockey Cup and tell them this is what we find, right? It is working, it is cost effective, and let's see what we can do, right? And then Jockey Cup say, okay, go ahead. Why don't we expand it? So this is the first phase, the exploration. We talk with the Jockey Cup. We explore the mutual interest. We also start talking with the partner in the community, because you cannot force an NGO to be in your program. You need to build a strong partnership, right, with the NGO. So we talk with the NGO. We learn what they really want, which kind of resources they think doable in the community. But doing a pilot project is more than just resources. You really need their heart and their soul, right? Otherwise, they just see it as a KPI, to fulfill. But then the project will not be successful. They really need to believe we are co-creating something for Hong Kong. And then in the preparation, the 1 year, right? So we start with exploring what model is available. Different type of step care model. We make reference to UK model. We make reference to Australia model. We make reference to US model. We look into how other countries. And then we start working with social worker, stakeholder in the community to develop, the step care model. And then we decide to not only put our social worker in the district elderly center, but we also believe the district mental wellness center has a very significant role to play. So we also invite them to be part of a team. So this is the preparation way. So we spent almost 1 year to develop the training model, to train the social worker, to develop the step care model. And then after 1 year, we focused on the model. We said we are not going to change anything for the next 2 years so that we can do a really good evaluation. And then so we implement the project in 4 districts between 2016 to 2019, and we serve almost 4,000 people. And then with effect, so 3,000 something people, we don't have 300 people, we don't have complete data, but we have complete pre and post data and the control group data. We have intervention data from 3,737 people, and we have control data from other districts, people with similar symptoms, but who are in a district who do not have joint age. So we use them as a control. So, and then we do the implementation. And after the implementation, we found out the effectiveness, right? We work with the Jockey Cup. They are willing to make another round of big investment to expand the project from 4 districts, 6 center, pilot project, to cover all the 18 districts in Hong Kong. And then so we start from the pilot, then we go into phase 2. So in phase 2, we add the ambassador into the program. We add the community-based participatory approach in the program. So we further invest more resources to build a safety net. So doing more preventive work. And then so phase 2 implementation was significantly affected by the COVID-19. So phase 2 is from 2020 to the end of 2023. But you know that the COVID-19 covered 2020, 2021, and 2022, right? That means pretty much we implement the expansion under the COVID-19. But to our surprise, the NGO part are really hardworking. We meet the number of people we serve, we patch in the beginning. And we also see very good outcome from those people. So at the end of beginning of 2023, we start talking with the Jockey Cup again, review the implementation in phase 2, as well as what we want to do if there is another round, right? You may remember, started from 2020, the government talked about primary health care. Before, in 2016, there is no primary health care. Okay, so then we ask a question, if we're talking about primary health care, WHO said no health without mental health. Can we say no primary health care without primary mental health care, right? So if that is the case, then what will a primary mental health care like in Hong Kong, right? So that becomes the core question we are asking in phase 3. So in phase 3, we continue the implementation in the 18th district, but then we expand our implementation to 3 district health centers. So we pair up with district health center. So to really look into identify the way to build a primary mental health care system for Hong Kong. So this is a summary of what we did for the Joyce project. So hopefully this is a very brief, a summary of 8 years of our life, right? It is really not easy undertaking. Think about, I came back to Hong Kong in 2011. So it is a little bit about 13 years. But out of that 30 years, 8 years is related to Joyce. So it is a large chunk of my career in Hong Kong, as well as in Hong Kong U. But I think it is really a highlight of my work at HKU and highlight, I think, the role of academic in the society, right? We produce very good paper, large number of very high quality paper in top journal. So we will not compromise on this one as academic. That is our primary duty. But we also equally put our emphasis on building a sustainable model in the community, so that if you go back to the first slide, right? Hopefully, in a few more years, we will see the trend of older people decreasing. Suicidal rate will continue. Changing the percentage by 1 percentage point for 30% of the population is really not easy. We are not talking about 10 people. We are talking about billions of people, right? So hopefully this trend will continue, and hopefully our effort, the whole Joyce team, not the team at Hong Kong U, not the social worker in the 51 center, but also the peer supporter and the ambassador will work together, to create a momentum of better care or better mental health care for older people. Thank you so much.